Assalamualaikum warahmatullahi wabarakatuh and greetings to everyone. In this case study video presentation for Advanced Immunology, we, the Group 6, will be presenting on our discussion for the case study on the topic of immunodeficiency. The case scenario provided for this case study are stated as follows. KD is a 36-year-old gay professional man who has been human immunodeficiency virus or HIV infected for 6 years. He had been on antiretroviral therapy or ART with Comdivir, which is zidovudine and emvudine and nalfinavir or Viracept. He self-discontinued his medication 6 months ago because of depression. The appearance of purplish spots on his neck and arms persuaded him to make an appointment with his physician. When he arrived at the physician's office, the nurse performed a brief assessment. His vital signs were 138/86, 130, and 100.8 degrees Fahrenheit or 38.2 degrees Celsius. Katie stated that he had been feeling fatigue for several months and was experiencing occasional night sweats, but he also had been working long hours, skipped meals, and had been particularly stressed over a project at work. The remainder of Katie's physical examination was within normal limits. The doctor ordered a chest X-ray, CBC, lymphocyte studies including CD4 T cell count, ultrasensitive viral load, cytomegalovirus assay, and a tuberculin test. Over the next week, KD developed a non-productive cough and increasing shortness of breath. Last night, he developed a fever of 102 degrees Fahrenheit and was acutely short of breath, so his roommate JF brought him to the emergency department. He was admitted with probable pneumocystis jirovecii pneumonia or PJP, which was confirmed with bronchoalveolar lavage examination under light microscopy. KD's admission, white blood cell, and lymphocyte studies demonstrate an increased pattern of immunodeficiency compared with earlier studies. KD is admitted to our medical unit and placed on nasal oxygen, IV fluids, and IV trimethoprim sulfametazole or Bactrim.
Question 1. What is PJP? PJP is pneumocystis jirovecii pneumonia, which was formerly known as pneumocystis carinii pneumonia. PJP is a fungus that can cause life-threatening pneumonia in immunocompromised patients, such as those with AIDS, organ transplant patients, or those with hematological malignancy. PJP lives almost exclusively in the pulmonary alveoli in human. The picture shows the gross experience of PJP in a lung. Note there is an extensive pneumonia in this patient. Adherence of pneumocystis to alveoli is not the singular cause of diffuse alveolar damage, but rather it is the host's own inflammatory response that causes significant lung injury and impaired gas exchange, leading to hypoxia and possibly respiratory failure. PJP spreads from person to person through the air. Some healthy adults can carry the pneumocystis fungus in their lungs without having symptoms, and it can spread to other people, including those with weakened immune system. The host immune response during PJP involves complex interactions between CD4 plus T cells and CD8 plus T cells, neutrophils, alveolar macrophages, and soluble mediators that facilitate the clearance of infection. Because of the progress in the antiretroviral therapy and the use of routine prophylaxis against PJP, the incidence of PJP in the HIV-infected population was reduced in most of the industrialized countries.
Question 2. What is the significance of the purplish spots over KD's necks and arms? The presentment of purplish spots over Katie's necks and arms is likely to be indicative of Kaposi sarcoma, precisely the AIDS-related type of cancer. Kaposi sarcoma is an indolent angioproliferative spindle cell tumor derived from endothelial and immune cell infected with human herpes virus type 8, or other referred to as Kaposi sarcoma herpes virus, which is commonly developed in the skin as well as inside the mouth and anywhere along the digestive tract, including the small intestines, colon, rectum, and anus. Meanwhile, its related type of Kaposi sarcoma is the most aggressive type as it disseminates to other distant organs in rapid manner. This type of Kaposi sarcoma is developed from the spread of the virus through saliva during sexual contact with the person with HIV. As the person with HIV have weakened immune system, they are prone to get infected with opportunist microorganisms such as HHV8 as in this case, and thus resulting to the manifestation of this disease. In the context of signs and symptoms of Kaposi sarcoma, apart of presentment of flat, painless spots of red or purple on the skin, with regard to cutaneous lesions, other signs and symptoms of this disease that presented on KDs are includes pulmonary lesions, which presented with non-pervasive cough and also shortness of breath, and B symptoms, which lasting more than 2 weeks, comprises of unexplained fever, fatigue, and night sweats. Furthermore, Kaposi sarcoma lesions might also potentially affecting KD's other body parts, including mucous membranes such as in the mouth and also throats, which causing difficulty in eating and swallowing food particles, lymph nodes, which blocking the flow of lymphatic fluid around the body and resulting to the severe swelling in the arms, legs, face or scrotum, as well as in the gastrointestinal tracts, which lead to bleeding and blockage and resulting to nausea, vomiting, stomach upset, and also diarrhea.
Question number 3. Differentiate between HIV positive status and AIDS. Okay, for HIV, the meaning of human immunodeficiency virus, which is a virus that invades and weakens the immune system of the body. HIV infection doesn't always progress to AIDS, which is HIV stage 3. Many people of HIV live for years without developing AIDS. So for HIV patient, they will suffer a minor difficulties similar to flu symptom. While for AIDS, which is acquired immunodeficiency syndrome, is a medical disorder. HIV infection can result in the development of AIDS. AIDS, also known as stage 3 HIV, occurs when HIV severely damages the immune system. A person can have HIV infection without having AIDS, but anyone diagnosed with AIDS already have HIV. So this patient will experience severe signs and symptoms disrupting the quality of life.
Why is KD's development of KS and PJP of particular importance in light of his HIV status? This is because the development of KS and PJP indicates that his HIV status has been getting worse and leads to the development of AIDS. KD started to show symptoms of AIDS. AIDS is a syndrome or range of symptoms that may develop in time in a person with HIV who does not receive treatment. KD has self-discontinued his medication for 6 months, which made him more vulnerable to various opportunistic infections that can attack various parts of his body. Kaposi sarcoma or KS is an illness that defines AIDS, which means it can occur in someone that has been infected with HIV and already have AIDS. PJP or pneumocystis jirovecii pneumonia is also one of the common defining illness of AIDS. It is a type of lung infection that caused by pneumocystis jirovecii fungus.
Question 5. KD has been seropositive for several years, yet he has been asymptomatic for AIDS. What factor might have influenced KD's development of PJP and Kaposi sarcoma? First, he discontinued his antiretroviral therapy medications, which may result in viral rebound and immune decomposition. Premature ART discontinuation can lead to the decrease of cell survival rate, lower CD4 plus T cell count, increased viral load, and increased drug resistance. Basically, discontinuation of ART medications can weaken his immune system and therefore increase the chance of getting infected. Overall, there is higher mortality rates and longer infusion times needed for treatment, especially when observed in non-AIDS patients. The second factor is malnourishment. He has been skipping meals, which makes him more prone to infections and more susceptible to develop AIDS.
Question 6. Identify 4 problems you must manage regarding KD. First, manage KD fever. HIV patient is high risk of fever because HIV causes defects in T cell function. Second, treat his PJP infection. PJP must be treated to reduce its severity and fatality potential. The most common treatment is trimethoprim and sulfamethoxazole. Third, provide a healthy and nutritional diet. Patient need to be provided with nutritional diet to help keep the patient strong, energetic and support the immune system. Fourth, hand washing and prevent other infection exposure. Personal hygiene practices are essential to prevent transmission and microbe exposure on HIV patient with highly susceptible to opportunistic infection due to weakened immunity.
Question 7. What precautions will you need to use when caring for KD? Firstly, KD is HIV positive. HIV can be transmitted via the exchange of variety of body fluids such as blood, breast milk, semen, and vaginal secretions. As a healthcare provider, I should wear protective eyewear, masks, or face shields during procedures likely to generate droplets of blood or body fluids. I do not recap needles, and I should dispose of used needles immediately into the sharp bin. Healthcare workers with open lesions should avoid direct contact with the patient. Next, KD is also confirmed with PJP. The fungus that causes it can spread from person to person through the air. Therefore, appropriate PPE, including respiratory protection with the use of an N95 or an equivalent mask respirator, should be implemented. Gloves should be changed after contact with the patient. Also, hand wash before and after dealing with the patient is necessary. Immunocompromised staff, such as elderly, are advised not to handle the patient because they are at higher risk of getting infected.
Question 8. What is the focus of your ongoing assessment? Literally, the focus of ongoing assessment on KD are divided into several aspects, which are monitoring his blood pressure, pulse rate, respiratory rate, and his body temperature. As to flashback, upon his first visit to physician's office, a brief assessment had been done on him and his vital signs are recorded, which that his blood pressure is systolic 138 and diastolic 86 mm mercury, 100 beats per minute for pulse rate, 30 breaths per minute for respiratory rate, and 100.8 degree Fahrenheit or 38.2 degrees Celsius for his body temperature. Apparently, these recorded vital signs are showing an abnormal and elevated range from the normal values of each signs, which that the normal blood pressure is systolic 120 and diastolic 80 mm mercury, 60 to 99 beats per minute for pulse rate, 12 to 16 breaths per minute for respiratory rate, and 37 degrees Celsius for normal body temperature. By that, these recorded informations are used to help diagnose the cause of the problem and also to decide which treatment is required. And so, a proper and supportive therapy can be given to him to treat and reduce the severity of the disease, and the continuous assessment on him is done as to ensure that his vital signs can be returned into normal and stable range, thus signifying the positive outcome of the therapy.
Question number 9. What major side effect of his antibiotic should you monitor KD for? So, since KD uses Bactrim as the antibiotic medication, it can induce a significant allergy reaction and others adverse effects such as severe peeling skin rash known as Stevens-Johnson syndrome. Besides that, it includes blood abnormalities, liver damage, and lung harms. So, medical attention is immediately required if there's any of the following signs such as itchy, sore throat, fever, worsening, lymph node swelling, paleness, joint pains, and other symptoms. Thus, The major side effects that usually should be monitored are sore throat or cough, trouble breathing, severe cramps or diarrhea, and unusual bleeding.
What aspects of KD's care can you delegate to the LPN, stand for licensed practical nurse? A. Administer first dose of intravenous Bactrim. B. Monitor KD's pulse oximeter readings, reporting values under 95%. C. Develop a plan of care to improve KD's oxygenation status. F. Reposition KD and having him deep breath every 2 hours. Licensed practical nurse is a graduate of a nurse school whose qualification has been examined by a state board of nursing and has been legally authorized to practice as an LPN. LPN qualified to perform any acts that are not requiring the skill, judgment and knowledge of a registered nurse (RN). LPN can be delegated to perform many tasks that are required to maintain patients comfortable while they are in hospital or any medical setting, such as recording patients' vitals such as blood pressure, temperature and pulse, reporting patient status to RNs and doctors and adding it to patient charts, changing wound dressings, giving medications, feeding and bathing the patients, and following healthcare plan developed by an RN or a doctor. LPNs are not qualified to be giving instruction about a high-calorie diet or high-protein diet, as it can only be done by a physician or RN that have generally completed more education than LPN. Furthermore, as this person is admitted to HIV infections and sign of AIDS developing, it is not suitable for his treatment to be giving instruction about diet and lessons about good hand-washing technique.
Continuing with the case study progress, KD is responding well to treatment for PJP and plans are being made for discharge. His antiretroviral therapy regimen will be restarted and he will be starting radiation treatments for Kaposi sarcoma. He will receive follow-up care at the outpatient clinic. Question 11. KD is kept on trimethoprim sulfametazole or Bactrim, 2 tablets once daily. He asked why he has to keep taking the drug since the pneumonia is gone. How would you respond? So it is still possible for the pneumonia to reoccur. Treatment for PJP should be done as soon as possible, especially if the patients have known risk factors and in cases of suspected infections. For mild cases of PJP, the treatments can be performed intravenously or by oral therapies on an outpatient basis. The first choice of drug is trimethoprim sulfametazole, which is well known for its efficacy. The main goals for this treatment are to fully cure the infections and to prevent any further complications. So it is very important to follow the treatment plan as suggested to ensure full recovery.
Question 12. KD was taught about disease transmission and safer sex and encouraged to maintain moderate exercise, rest and dietary habits when he was first diagnosed as HIV positive. Give at least 4 additional topics that should be discussed with KD before he goes home. First, KD should not skip his medication and follow doctors about his prescription. It is crucial to take HIV medication. Skipping even 1 day of medication can give the virus an opportunity to become resistant to the drugs, making them ineffective against the virus. Second, talk about the side effects of his medication. Side effects of HIV medication may last only a few days or weeks. For example, nausea, fatigue and trouble sleeping. Third, KD should also know what germs he is exposed to. He has to limit himself to expose to farm, stray or unknown animals. Lastly, prevent infection and illness. Since HIV makes the immune system less effective and the patient becomes more susceptible to microbes he was exposed to, wash hands frequently and stay away from sick people to stay healthy as possible.
Question 13. What laboratory data will most likely to be monitored in KD in the future? In general, CD4 cell count and viral load tests are used to monitor whether HIV treatments are working effectively to control HIV. In addition to these tests, CBC, complete blood count, biochemical tests, and drug-resistant tests can be performed in the future. First and foremost, as a biomedical scientist, I should test KD's CD4 cell count in the future. CD4 T lymphocytes help coordinate the immune response by stimulating other immune cells. HIV binds to the CD4 molecule on the surface of helper T cells and replicates within them. This results in destruction of CD4 plus T cells and leads to a steady decline in the population of T cells. When CD4 cell count drops below 200, a person will have progressed to AIDS. The rate of CD4 cell recovery is typically most rapid in the first 3 months of suppressive antiretroviral therapy, followed by more gradual increases over time. Second most important laboratory data will be HIV viral load. HIV viral load test is a type of HIV test that measures the amount of HIV genetic material in the blood. A typical viral load in someone not taking treatment may be 50,000 copies per microliter of blood. After starting HIV treatment, viral load usually falls rapidly. Within 3 to 6 months, most people's viral load has become undetectable. A viral load that can't be detected less than 120 copies is always the goal of HIV treatment. This doesn't mean the patient is cured. Unfortunately, the virus is still able to survive in various cells in the body. But maintaining an undetectable viral load is compatible with normal or near normal life. Third laboratory data that should be monitored is complete blood count. A complete blood count is a set of medical laboratory tests that provides information about the cells in a person's blood. The CBC indicates the counts of white blood cells, red blood cells, and platelets, the concentration of hemoglobin, and the hematocrit. The normal range of these blood components is altered during an infection. For HIV-infected patients, the eosinophil count increases, and the other blood cell components decreases as the CD4 cell count decreases. Eosinophilia during HIV treatment indicates recurrent infection or other opportunistic infection. KD should also monitor for biochemical tests. Long-term administration of the drug should be guarded to avoid possible drug-induced liver injury. The biochemistry findings will show an elevated liver transferase enzymes if there is a liver injury in the HIV patient. Also, albumin, a protein made specifically by the liver, will be slightly decreased. HIV infection can damage the kidneys and lead to kidney diseases. Plasma creatinine and urea, an excellent indicator of kidney function, will be also low in HIV-associated nephropathy. Lastly, as a biomedical student, I suggest the doctor to take drug-resistant tests. If the person stops taking HIV medicine, the virus begins to multiply and mutate. Some HIV mutations can cause HIV drug resistance. A drug-resistant test helps the healthcare provider identify which, if any, HIV medicines will not be effective against the strain of HIV the patient has, and choose which HIV medicines are most likely to work for him.
Question 14. List at least 5 other opportunistic infections that KD is at risk for developing. As KD is HIV-infected individual, he is in the highest degree of exposure and tendency to be infected with opportunist microorganisms, resulting to the possible manifestation of diseases as follows, which are gastroenteritis, which characterized with an inflammation of the lining of the intestine caused by a virus, bacteria, or parasite; encephalitis, which an inflammation of the brain and most commonly caused by viral infection; meningitis, which an inflammation of the protective membrane covering the brain and spinal cord resulted by bacterial or viral infection of the fluid surrounding the brain and spinal cord; pneumonia, which an infection that inflames the air sacs in one or both lungs caused by a variety of organisms including bacteria, viruses, and fungi; and also tuberculosis, which a disease caused by bacteria known as Mycobacterium tuberculosis, which commonly attacking the lung and also capable to damage other parts of the body. These are the list of references from various sources which had been utilized in our discussion on this case study. We would like to thank everyone for the attention given for our case study video presentation. With that, thank you.